Good evening, and welcome to the University of Findlay Doctor of Physical Therapy Student Research Forum. It is a pleasure to have our students, faculty, clinicians, family, and friends gathered here today in support of student scholarship and professional growth. This forum represents the culmination of months, often years, of dedication, curiosity, and hard work. Our DPT students have invested significant time and effort into asking meaningful questions, critically analyzing evidence, and translating research into clinical relevance. Research is fundamental to advancing the physical therapy profession. It drives evidence-based practice, informs clinical decision-making, and ultimately improves the care we provide to our patients and communities. Today's presentations reflect our program's commitment to inquiry, innovation, and excellence, and we are really proud to showcase the scholarly contributions of our students. Thank you all for being here to support this important work. It is now my pleasure to introduce our Dean of the College of Health Professions. Under his leadership, the college continues to foster a culture that values academic rigor, interprofessional collaboration, and meaningful scholarship. Please join me in welcoming Dr. Richard States, Dean of the College of Health Professions.
So first and foremost, they make me sound like I do something. I don't do anything, okay? It's all the hard work of our students and our faculty and staff that make me look good. Hopefully I look good tonight, so, okay. I also want to make sure that I welcome you guys to our research forum this evening. It is very important that we take time to recognize the hard work that our students, soon-to-be graduates, have put in, and we want to make sure that we acknowledge everything that they've done. It showcases their hard work and helps us celebrate some of their huge achievements. Again, my name is Rick States. I'm the Dean for the College of Health Professions. One thing to keep in mind is, students, this is all for you. We are celebrating your achievements. We are thrilled to have you as part of our soon-to-be alumni. Take a moment. Think back to the very first day when you started the program. How nervous you were. All the creepy thoughts in your head. Am I going to be successful? How hard is this? Can I bluff my way through? Hopefully you didn't bluff your way through. Again, the activity that you've had while you were out in experiential education has created a fantastic base for you to build on. But keep in mind, as hard as it was, you have succeeded. That's the most important part. Nothing in this world comes easily. As you have found out, the Doctor of Physical Therapy program is not easy. It is by far one of the hardest programs that the University of Findlay has to offer on our campus. Occasionally, there were hurdles that you needed to clear, but you cleared them, and you cleared them with grace, hard work, dedication, and a positive attitude. I challenge you to continue this practice throughout your life, both professionally and personally. From time to time, there's going to be setbacks. There's no doubt about it. But please make sure that you understand that you now have the basis for overcoming some of those issues and problems. You have some of the best educational training in the United States. You will succeed in your chosen field. Again, we are looking forward to welcoming you into the alumni family here at the University of Findlay. So on behalf of the College of Health Professions and the university, congratulations. Thank you.
Thank you, Dr. States. And now we'll start our research forum. First, I'm going to ask our University of Findlay Student Physical Therapy group of research presenters to come on up.
Hello, everyone. Welcome to our presentation regarding our study looking at hip rotation strength and ground reaction force in males and females with low back pain. Ground reaction force is representative of how the body and the ground interact during both stance and movement. Ground reaction force provides insight to potential musculoskeletal impairments, compensations, and limb symmetries. Ground reaction force is typically balanced between the limbs in healthy individuals, and asymmetry in ground reaction force may indicate weakness at the hip, foot, ankle, or the low back. Muscular imbalances are known to increase the risk of pain and or injury. Previous research shows correlations between certain musculoskeletal conditions such as patellofemoral pain syndrome and lower limb asymmetry and hip strength. The relationship between ground reaction force asymmetry and hip strength, especially rotation strength, has not been thoroughly examined, and for that reason, the purpose of our study is to determine if there is a correlation between rotation hip strength and ground reaction force asymmetry in male and female adults with low back pain. And here is Josh with the participant demographics.
So a summary of the participant demographics, just some of the things. We had 19 adults, 68% of which were females. And then we had an average age of 28.1 years. And then kind of looking at the lower back pain range was 1.9 years, and 94.7% were right-handed. And the BMI average was 28.7, which is basically meaning that the average people in our research was overweight. And here we have Will with the methods.
For our methods, we assessed hip internal rotation strength and hip external rotation strength utilizing manual muscle testing, the manual resistance applied by physical therapists. We assessed ground reaction forces utilizing 30-second static stances on podium force plates. These manual muscle test scores were then converted to a decimal point scale. Independent t-tests were utilized to assess the differences between hip strength variables and ground reaction forces between the sexes, while Pearson correlation coefficients were utilized to assess the relationship between these hip strength variables and unilateral ground reaction forces. And up next is Zach.
Hey guys, so I'm here to talk about the results of our study here. So first here, you'll see a couple of charts. So the first chart here is comparing the mean hip strength for internal and external rotation between the males and females. So Will said we used the independent t-test, so we used a two-sample t-test with unequal variance to compare the two groups. And what we found was that there was no statistically significant difference between the hip strength between males and females. And also with our smaller sample size of only 19 people, with the majority being females, hip internal rotation and the external rotation strength was found to be comparable between the two sexes. So with no strength difference, we then focused more on the different asymmetries between the two using ground reaction force. So this next chart here is looking at left versus right limb ground reaction force, comparing that between females and males with the low back pain. So a two-sample t-test with the unequal variance was also ran this time around as well. And in this case, there was again no statistically significant difference between the ground reaction force using that force plate and between males and females as well. So although the mean ground reaction force values were similar, we then examined whether the asymmetries existed between the two limbs. So the next chart here, this is the p-value. So with a p-value less than 0.05, we're looking at something being statistically significant. And so within our sample, comparing left versus right lower limbs, we used the paired t-test, and we found that in females, there was a significant difference between left and right ground reaction forces with a p-value of 0.01. And in males, there was not a significant difference between the two with a p-value of 0.51. So now, recognizing this, we then examined whether left versus right hip internal or external rotation strength was related to males and females ground reaction force. So the last slide here. So the highlighted ones are the ones that I want to pay very close attention to. So this table summarizes the Pearson correlation coefficients that we found for the hip rotational strength and the unilateral ground reaction forces. So as you see, the correlations are presented separately between the females and the males. First I'll talk about the males. So in males with low back pain, we saw that both hip internal and external rotation strength demonstrated moderate to large correlations with the ground reaction force. So these correlations were present between left and right, which is highlighted by the larger R values of 0.72 was the greatest one for the right ground reaction force. Now for females, the pattern was more specific. So we found that only right hip internal rotation strength for females had a significant correlation. So right ground reaction force with right hip internal rotation strength. So now I'm going to hand it over to Jacob to talk about what we can conclude from those results.
So overall, there was a strong correlation between the right hip internal rotation strength and right hip ground reaction forces, specifically in females with low back pain. There were notable asymmetries with women who had low back pain. This was looked at with a reduced force on the right lower extremity, which led to compensatory leftward shifts. Right-hand dominant participants that we had in our study also showed that there were musculoskeletal, postural, and neuromuscular tendencies that may have led to both conscious and subconscious contributions to their low back pain. The emphasis that we had was a broad relevance with hip internal rotation strength, specifically with individuals in low back pain. There were no significant differences that we found between genders when it came to hip rotation strength and ground reaction forces. However, we did find specific asymmetries with females that had reported low back pains. This may suggest that they had neuromuscular strategies for balance and force tendencies that may be regulated differently compared to males. This may influence the compensatory patterns that men have compared to women when it comes to low back pain. As we look at the biggest limitations that we had in our study, it came with the sample size. Our target that we wanted between Findlay students, faculty, staff, and community members were 94 participants. However, we only had 19. So when we ran our statistical power software with a two-tailed Pearson correlation coefficient and an effect size of 0.6, we were trying to get a power of 0.8, but we weren't able to achieve that power just due to the small sample size that we had for our study. And Alyssa Gazaric will take us away with our clinical significance.
Hello, everyone. So based upon the results of our study, we just wanted to provide some practical ways that you can use this information and translate it to the clinic and just overall the ways that you practice as physical therapists. So the first way by doing that is, especially with our female patients where we see this left-sided weight shift, we can help manage that low back pain specifically by doing right hip internal rotation strengthening exercises for that. And for males and females as well, bilateral hip internal rotation strengthening exercises can be of a benefit as well. In the following ways, so we can see decreasing compensatory weight shifts, we can improve the symmetry with their ground reaction force, we can improve any muscular imbalances in the lower extremities, and we can treat low back pain and its connection with the hip and pelvis musculature. And then lastly, if your setting has the proper equipment, you can incorporate ground reaction force testing into your initial evaluations in order to identify these subtle asymmetries right off the bat and direct your plan of care from there in order to help these patients return to their prior level of function in the most efficient way possible. So if you have any further interest in this topic, these are our lists of references, and we thank you for listening to our presentation, and we'll go ahead and open it up for any questions at this time.
Excellent job in presentation, and those statistics, those are tough and those are big, so great job working through those. My question for you, as you determine those relationships of hip internal rotation and ground reaction force, what curiosities or questions do you have that you would perhaps explore in your next study?
So, like, building upon what we already studied? Okay. My biggest takeaway that I would want to study more on is the chronicity of the low back pain. Like, looking at, like, are we going to take people with 3 months of low back pain that maybe just had, like, a twinge twice? You know, there was some subjectivity to it. I would like to, if we're going to go further in research, and I know the next year's cohort is actually kind of building upon this research as well to have more variables as well. But I would want to look at the chronicity of the low back pain to make it more specific to allow for less subjectivity. That's what I would want to do. Anyone else want to? All right, cool.
Can you further expand on how you correlated right hand dominant to unconscious and conscious pain?
I told them I wouldn't leave them stranded and that I would help if they had any questions. So how we're looking at it subconsciously and consciously is not necessarily in relation to pain, but in relation to movement patterns and how those neuromuscular movement patterns can create pain. So one thing we talked about looking at right hand dominance, especially in a female population, and one thing we're also going to expand on is looking at maybe differences in women who've been pregnant and delivered and those who haven't. A lot of times, if anybody in here is a parent, you know that maybe if you're right hand dominant, you may load one side constantly so that you have one arm free to do all the things. So where we're looking at it is then does that correlate to a subconscious shift constantly that relates to pain?
Before you did the ground reaction force determination on the force plates, did you do any type of orthopedic exam or screen to look for those postural asymmetries or handedness patterns or leg length discrepancies prior to the testing?
We did not do any specific examination, except we had just Alyssa do the manual muscle testing, so good intra-rater reliability. But in terms of doing like a formal examination, it was just the manual muscle test before doing the ground reaction force.
Okay, and next I'm going to welcome our next presenter, Luke Clayman, a physical therapist with Lima Memorial Health System. Come on up, Luke.
Hello, everybody. I've never used one of these clickers before, so this is going to be fun. Okay. So I have a patient case study that I'm going to be going over. Big word, homogeneous hemianopsia. I hope I said that right, but you know, I'll let my former professors correct me if I said that wrong. But so basically what this is where there's a lesion to a part of the brain back in the occipital lobe that causes one side of the visual field to be not necessarily perceptive to the brain. So as you can see here on the brain here, if one part of the occipital lobe, if there's a lesion there, then you're not going to get either the left side or the right side going to the brain. So my patient case is a 17-year-old female. She had a tumor in her brain. It was removed. After the brain tumor was removed, she noticed she had some visual loss on the left side of her vision. And yeah, after the surgery, she had left-sided vision loss. Vision tested confirmed that she had homogeneous hemianopsia, and then she was referred to me for physical therapy. We did a lot of vestibular type training as well as visual. So some of the intervention strategies I went with are some dual tasking, some obstacle navigation, sport-specific agility drills, dynamic visual field scanning, and vestibular visual integration. So what this really looked like in the clinic is a lot of like saccades with eye movement training, some peripheral field simulation, some different visual field occlusion, and then a bunch of just functional everyday tasks such as scavenger hunts or different reading things where I made her circle different things in her peripheral vision while she was reading certain paragraphs. So some equipment use, a lot of it was kind of do-it-yourself type equipment. Most of the equipment that I used was things that you can do for very cheap. There wasn't really anything expensive that I had to buy. So first was just do-it-yourself Hemi glasses. So I took a basic pair of $3 Amazon glasses and I cut out a bunch of pieces of paper and stuck them on the left side of the glasses, or no, sorry, the right side of the glasses to force her to look over towards the left side. I also used a lot of mirrors to force her to look in different areas of her peripheral vision. I did a few vestibulo-visual type exercises, such as using a Marsden ball, a heart chart, barrel cards, and a box bowling ball. You'll see these kind of later. I know these really mean nothing to most of you sitting in here, but I'll give you a better description of kind of what these all meant. And then also some sports-specific things. She loves soccer, so we did a lot of soccer activities. So soccer ball and cones and hurdles. So first I'll go over some of the visual field training activities that I did with her. So first I have I don't even know how they explain it. Yeah, just use the video. That's going to be the best. And you can see I used a lot of different mirrors, and I had her stand on one side of the mirror in order to force her vision to be exactly where I wanted it to be. And then I have these two strings where she would basically pull a golf ball all the way up, and she had to avoid all of the holes so that way the ball didn't fall into the backside of that. And there's kind of a demonstration of how she was holding one string with one hand, and she'd have to pull it each direction in order to get it to go all the way up. I guess it's kind of like one of those Plinko boards, but opposite. So next I'm going to go through some vestibulo-visual type interventions that we went through. So this one is the Marsden ball. Basically what it is it's a ball that's hanging from the ceiling. Oh, that's sideways. But this is a ball that's hanging from the ceiling. It has a bunch of different letters and numbers on it. And what I would have her do is she would have to walk in between the ball while it was circling around, and then walk outside of the ball without getting hit by the ball. So this helps train her peripheral vision by making her realize where the ball is at around her without getting hit. Sometimes I would have her look for certain numbers or certain letters and tell me, are they in the top row, the bottom row, in the middle? And it would force her to kind of lock her eyes onto different areas of the ball to see if she's actually scanning and looking for different areas. Next, I have a heart chart. Again, a bunch of just random numbers and letters. And then I had a orange stick on the side, so I'd have her read out the letters and numbers while she was in a plank position. And then I would use the orange stick to move it around in her left visual field. And then while she was doing that, she would either have to tell me, if I waved it fast, if I waved it slow, if I waved it up high, down low. And by having her do that, it made me see if she was just kind of guessing, if she thought she saw it, or if she was actually seeing it. Starting out, it seemed like she had a 25% guess ratio. And as she got better at it, it turned more into maybe like a 60% accuracy. So here's kind of how I did that. The next one, we had a box bowling ball. So basically, I would have her punch it, and it would keep coming back to hit her in the face. And sometimes I would move it over to the left side or the right side to see if she could attend to that left visual field and still hit it. I think her record was 8 in a row. This was not necessarily the best one that I had of her, but it's the only one I had a video of. So I'm sorry to the patient that didn't get to have the video of her doing a whole bunch in a row where she was doing really good. These are barrel cards. So basically what I had her do with these is on one side it's red and on the other side it's green. And this is forcing her to use both her left and her right eyes to converge onto one single point. So on one side it's red, on the other side it's green. It's almost like when you have the 3D glasses when you go to the movie theater. You're trying to converge the two colors into one single point. And she would hold it up just like this, and she would focus her eyes on each individual spot, and that would work on more of the visual piece of that. And then going into the sport-specific interventions we did a lot of keep away with the soccer ball. I would specifically be really mean and go to the left side and try to kick it out of her way. And then we would go around all of these cones and obstacles while we did that. Sometimes I would throw a few hurdles in, and I would make her step over the hurdles. And I would sometimes purposely put them at an angle, so that way she had to know if she was just guessing if she was stepping over, or if she actually could see it out of that visual field to the side. And sometimes I also threw a tennis ball at her, which you can vaguely see. So here's kind of the fun part, the results. So on the left side is what her right eye, what her vision saw back in April. And then on the right side is what her right eye saw in August. So you can see quite a big change with what she's picking up out of that right eye. And then the left eye, same thing. It's the change from April all the way to August. So I was pretty shocked when I saw the results here. Some of the limitations, it's hard to know how much of that visual field is from the therapy versus how much of it is maybe from reduction of swelling from everything with the brain surgery. I will say the picture that I showed on the left side, that was taken I think maybe 3 weeks after the surgery. So theoretically, a large portion of the swelling had already gone down by the time that test was done for that initial eye test. But it's still hard to say if there was any swelling present. Obviously, that's not something that I can directly test through the initial therapy evaluation. And so the gains were most likely a combination between some of that physiological swelling going down as well as some therapy interventions. So conclusion, that patients will have the best outcomes whenever they're managed through interdisciplinary care, whenever they have their therapy tailored towards their goals with an impairment-based approach. So kind of like how I said earlier, she had a very big passion towards soccer. We put a lot of interventions based towards making sure that she didn't let the ball get away from her, especially with, if you're a defender, you want to make sure that you can kick the ball out. If you're an attacker, you want to make sure the ball doesn't get kicked away from you. So really trying to tailor that into what she did in her sport was really important and made her feel like she was making progress throughout the therapy. And then also creating interventions that target the neuroplasticity. So everything that we basically did during her therapy is trying to get her to reattend to that left side. One thing that I saw initially is she did a lot of just turning her head every time she had to look over towards the left side. Her body basically learned that if she looked to the left with her eyes, she didn't really see what she needed to see. But by adding the head turn, she was able to see what she needed to see on the left side. A lot of the therapy combined a little bit of, how do I say it, like a mix of compensatory versus treatment for the saccades versus the head rotations, because we kind of want to mix. It's very inefficient to constantly move your head every time you want to look towards the side and see something. Trying to get a mix of moving both her eyes as well as moving her head when she needed to see something towards the left side and attend to it, as well as training her body to be able to look more towards her peripheral vision and see if things are moving or anything like that. Any questions about anything? Yes?
What was your prescription? Like how frequently?
Yeah, so I saw her once a week for 3 months. Good question.
What was your prescription for?
Yeah,
physical
I saw her
therapy?
once a week for 3 months.
Thank you very much.
The video won't pick it up.
And then how soon after surgery did you get to start to work with her?
I started in June, so it would have been about a month and a half.
Very good. And then the technology that was used to measure the changes in her vision, was that done through ophthalmology, or I guess, what was that technology?
So yeah, she did, and basically the same thing you get when you get your driver's test done, and they do the little blinking lights. It tests based on how bright the light was when in different parts of your visual field. So yeah, she did it through the ophthalmology clinic with the neurologist.
Do you feel like there's a window of time for this remodeling to happen, or you had the acute phase after surgery? What about 1 year later? Do you think you would have similar results, or have you had any research that shows similar results?
I would say, based on my own experience, definitely the sooner, the better you're going to have the window. Whereas maybe later on, you might not necessarily make those neuroplastic changes as much, but you can still make the behavior changes. So kind of like what I was saying with moving your eyes versus moving your head, you might not get as many of the neuroplastic nerve changes to show some of those similar results, but you can still get some of the behavior compensatory changes because the behavior has a big piece to how they function, if that makes sense.
Nice. I have a question. So you had the ophthalmology results that showed the change in her vision. What type of objective measures did you do on eval, and did you see changes in your own objective measures as treatment carried on?
Yeah, so I didn't know exactly what I was all going to look at the very first day, so I did the entire gauntlet of everything I could think of the very first day. I'm thinking, I did the Michigan tracking test, which is basically, it looks like a whole bunch of mumble-jumbled letters, and what you do is you're going to go through and you like circle like A, B, C, D, and you have to look very specifically for every single letter. I I almost wish I could just show you how to do that up here, but it's a very specific saccade eye tracking test. So that was one of them that I did. The test is to see how long it takes to get through the entire paragraph, as well as how many errors she made. So that was one thing I did. I did a lot of vestibular testing, so like gaze stabilization. I did balance testing with eyes open, eyes closed, foam pad, head turns. I did, let me think. I'm sure there was a lot more. That's all I can think of at the moment. Yes, so I'll say the Michigan tracking test I was talking about first. I think the very first day it took her maybe like 2.5 minutes. And within like 4 weeks, I already saw really big changes with that. I think she got it down to like 1 minute and 10 seconds. And all that came down to the ability to look at the saccades a lot faster. She was able to go through with a much more efficient saccadic eye movement pattern every time she circled the letter, which made reading a lot easier for her. When she first came to me, she said reading was very difficult, especially with studying, and you've got to look always on the left side of the page, start left as you read all the way to the right. Just basic, simple compensatory measures such as putting a ruler underneath the line and reading like you're a kindergartner with your finger. That helped for the first few weeks, and as that continued, she no longer needed to do that. So almost those basic retraining kindergarten type reading exercises helped retrain her how to get back to her normal. Yes.
So anatomical question, and this goes to the question of whether or not the recovery has to do with compensatory neuroplasticity, or relief of edema and things like that. The neoplasm, was it limited to the cortex, or did it encroach onto the optic radiations? Do you know?
I do not know. I know when they initially found it, it was in the temporal lobe,
Yeah.
I think, and then some of it went towards the occipital lobe. I don't know the exact location of if it went into the optic radiations. But I will say it was really cool when I looked at the all of her ophthalmology testing, because you could see like the macular sparing and everything. That was just really cool to see, just right in the center of the eye. It was immensely perfect. So that was really cool. That might not have answered your question, but that was just a cool tidbit I threw in.
All right. Thank you.
Thanks.
Thank you, Luke. Next, I will invite up physical therapist Heather Chenault and occupational therapist Mary Fenner.
Oh, there we go. Sorry about that. I'm not even sure what button it is I'm supposed to click, so I just pushed them all to one list. Okay. Okay. Hi, guys. I'm Heather Chenault. I'm a physical therapist.
I'm Mary. I'm an occupational therapist. I feel like I've infiltrated something here.
And we're both developmental therapists at the Nationwide Children's Hospital at The Ohio State University Wexner Medical Center. And we're super honored and proud to come present our current and ongoing project with our late preterm infants, the therapeutic interventions of the late preterm infant, as we call Small Baby School.
So the big why did we create Small Baby School? As Heather mentioned, we work in the neonatal ICU predominantly. If you are a baby born or a family that has a baby at 34 weeks and below, that's an automatic admission to our NICU. We have a subset of 35 to 36.6 week infants that are called late preterm. They're often at risk and underserved. They're often referred to as the great pretenders because they appear like typical 40-week infants and are often treated as such. The problem being that they are at higher risk for things like hypothermia, hypoglycemia, feeding difficulties, and weight loss. And no pun intended, all of those seem to feed into each other. So again, why do we create this small baby school? Some of you may know, having a new baby is stressful. Having a new baby that is premature is incredibly stressful. So we wanted to find a way to proactively serve these vulnerable patients and these vulnerable families. Oh, I thought you were the clicker.
I'm sorry. Okay. Oh, guys, I'm sorry. New to this. Okay, so she explained the why, but now I'm going to explain the how we do it. So here is a process map of our process. So we're currently serving 35 weekers. So any baby that is born at 35 and 0 days or 35 and 6 days old between those weeks are going to get an automatic order from our physicians as long as they're strong and robust and can remain upstairs in our Well Baby clinic, Well Baby nursery. And so once we get the consult, we go through the chart review and make sure the baby qualifies. We talk to the nurse and find out its best schedule for the baby, and then we head upstairs to go see the baby. Walk into the room and we introduce ourselves to the parents. We do try to make sure, knowing that the mom just gave birth to this baby, that we give at least 12 hours. It doesn't sound like a lot, but they're only in the hospital for 24 to 48 hours. Sometimes if a C-section, they stay a little longer. So we want to catch them. But we're going to introduce ourselves and we're going to kind of explain that we're there for the baby because it's a late preterm infant, that there's nothing wrong with the baby, but we want to make sure we give them skills and tips to keep the baby robust. And then once we have the parents' consent, we're going to give them a Likert scale of confidence and competence on bathing and dressing, developmental play, and feeding. Once that's done, or during the time the parent's filling out the survey, Mary and I are going to assess the infant. We're looking for any anomalies like head shapes, muscle tightness, tongue ties, anything like that that might tailor their program even further. And then we're going to ask the parent if there's any specific concerns that they've noticed already in those first few hours with the baby, or maybe they've had a previous infant that they had difficulties with that they want to be addressed, because we want to make this program encompassing the needs of the family and very specific to the individual patient. So some of the hands-on training and education that we do provide will be on bottle feeding, breastfeeding tips and tricks, developmental play recommendations, environmental adjustments, because as Mary said, a baby born at this time, his brain's only about 2/3 the size of a baby born at 40 weeks, so there's a lot of things that can overwhelm the infant. Thermoregulation and then swaddling. Once we've provided hand-on education and kind of vetted out any concerns the parent has, we're going to provide them with a handout that we've made and created, and then we're going to give them that post-survey. It's the same 3 questions on their confidence and competence, and then we are often usually only in there for 1 visit, usually about an hour we spend with the family and the baby, and then we just let them know that we're there the next day, and if they have any questions, concerns, that we can come back up and address any of those questions. So what did we find? So this is my favorite, this is my favorite statistic. So this is the Likert scale we use. So we have found an increase in confidence, which I think is wonderful, because like she said, it's scary to be a new mom, and especially scary with a late preterm infant. So the pre-survey for their confidence was about a 3.7 per scale, and then after we increased to a 4.47, which is showing an average parent confidence increase of 21% after having just an hour with us. We also saw that of the babies that did not attend the small baby school, 37.5% of them ended up in the NICU. And of the babies that did participate in the small baby school, only 5.4% of them ended up in the NICU. And it's important to note that it is expensive to go to the NICU, about $11,000 for an admission into the NICU.
Per day.
Per day. So what we're finding in this like new and green project is that we're increasing parents' confidence and competence, and we are hopefully decreasing admissions. So we're sparing these new parents or veteran parents from having the traumatic experience of having a baby go to the NICU. So we're thinking it's very beneficial.
So like Heather said, our main goal is to prevent NICU admission. Beyond that, we're looking to prevent hospital readmission and again, overall, increase parent confidence and competence. So what's next? Like Heather also said, we work at Nationwide Children's. We're on Nationwide Children's floor, but we work at Ohio State on the main campus. There is a gap between those two hospitals that we are unable to see currently our readmission rates. Babies that leave us from the Well Baby Nursery or the NICU cannot come back and have to go to the Children's Hospital. We're looking for a physician or someone that can help bridge us that gap, that champion that can follow readmission rates and readmission causes. Additionally, we'd love to follow up with parents at that 6-month mark. How do they feel at that 6-month mark? And then looking back, hindsight is 20/20. Reflecting, how do you feel about that postpartum, that scary, fresh postpartum phase that you had a little extra support or a little extra education? And then beyond that, we would love to expand out to more schools. Seeing 35-week infants is good. Seeing 35, 36 weeks infants is great. And then creating a potentially new school for those infants that we call neonatal abstinence syndrome, NAS, or NOWS, neonatal opioid withdrawal syndrome, infants that have been exposed to drugs. So providing support to those families as well. And Heather and I have been told that we are a lot, but we still need more. So we would just have to grow our staff significantly. That's kind of a limitation right now.
So we're excited about the things that we've seen so far for this program and are excited to see where it goes. But we wanted to open it up now to any questions that people may have.
Do you have speech therapists involved with your clinic? Or are you looking at that as part of your growing your staff?
No, there are no speech therapists in the neonatal ICU on Ohio State's main campus. There are only 4 therapists in the NICU at Ohio State. We feed into a much larger children's hospital, and they do have speech therapy throughout multiple subsets of their NICU floors.
Hey, so when you're working with the parents with their babies, I know it depends on each baby to baby, but about what percentage is education and what percentage is actually hands-on with the baby? Is it, or is the majority one or the other?
I'd say it's pretty concurrent. So typically, we kind of have a flow, like we've assessed the baby. So typically, I start off with educating on how to swaddle, and I am demonstrating on the baby, having the parents do their thing and doing on the baby, and then it kind of naturally flows into the feeding. A late preterm infant needs to be swaddled and contained to feed effectively. So then Mary will go into her spiel. So it's kind of at the same time. She's feeding the baby with the parent and educating them. Sometimes if maybe Mary needs to do a little longer with the feed to assess, I might start jabbering a little bit about some things and talking to the parents. Sometimes it's multiple family members in there, so I can pull one aside and educate on one topic while she's educating on the other. So I'd say pretty concurrent.
I have 2 questions for you. The first one, it's tough. Like I think about how you were able to maybe follow them longer term. I'm sure once they're out into the world, they're everywhere. But I mean, being at Nationwide, you know, how are you working with pediatricians to perhaps try to get some more data down the road?
That is the goal. We're still working on that. That's really one of our main focuses to follow up, but we do not have access to that information right now just because of HIPAA and the 2 different hospital systems.
And then with regard to your research, where else have you presented your work?
Predominantly just the symposiums at Ohio State.
Thank you. Our last presenter this evening, I will welcome physical therapist Jennifer Shepard up to the podium.
Thank you. Okay. Hi, thank you so much. I'm Jennifer Shepard, and I graduated from the University of Colorado way back in 1999. I grew up in the Port Clinton area up on the lake, and then life brought me back to Ohio back in 2018. I have a private practice in Cleveland, Ohio, and then I live up in Marblehead, so I'm very grateful just for this opportunity to share this case. So this is Jake. He and his mom have given me permission to share pictures and share his story. And as we see this picture, and what really prompted me to really put this data together and start to present this, I got to go watch him play on his senior night this year, football, and to watch him on the field. And I had not watched him play before. I had only seen him in the clinic, but the swagger, the confidence, the smile, just was so exciting for me to see this boy shine and have so much joy. Not only that, but as I sat with the parents, his dad came up to me and said, thank you so much for not just helping my boy, but my wife has so much less anxiety and worry, so thank you. So this is Jake's story. Here we go. Actually, maybe real quick. So my evolution as a physical therapist, I've been a PT for 26 years. I kind of worked my way around orthopedics, into school, trying to figure out kind of where do I belong in the PT world. I ended up starting to study with the Institute for Physical Art, which is a manual therapy organization, which the foundation is in PNF, but then we start to do manual therapy, soft tissue joint work on top of PNF work. So I did certification in manual therapy through that organization in Steamboat Springs, Colorado. And then that took me into fellowship, so I did a year-long fellowship with the Institute for Physical Art, which granted me Fellow of the American Academy of Orthopedic Manual Physical Therapists, which we meet once a year, continue to promote manual therapy in our field. And then through there, I started to study with the Barral Institute, which he's a French osteopath and has been bringing his work to the States probably since the late 80s, and I found a great mentor in there. And we start to take the work deeper into the anatomy, into the container. So we start to go into visceral vascular neural manipulation through fascial relationships. So that evolution, as we started to come into the container, I started to treat more digestive issues, and I still treat ankle pain, back pain, but it just started to open up the opportunity to help more people with more diagnoses or issues. And then that last certification, just a couple years ago, that next evolution was certification in functional medicine through the Institute for Functional Medicine. So really, as I treat patients, I look at the whole person, a system approach versus symptoms. So he was a 17-year-old boy, post-concussive syndrome, and chief complaints: school performance, anger, anxiety, depression, poor sleep, and no energy. And often those are symptoms that we typically don't see in our clinic. So, what do we do with that as a physical therapist? And his mom had reached out just, hey, we heard you do some different things. You do some help, work in brain health. We'd like to see what else you can do to help us. His biggest concussion was in 7th grade, high jump. He missed the pit and landed posterior. So he had seizures and vomiting after that. He did end up at Nationwide Children's. They did EEG and lots of testing, which often concussion does not show up on a lot of the testing that is done, CT and such. So he struggled to recall his whole 8th grade year. So that was the severity of that concussion. He eventually got himself back to sport. He's hanging out. He's doing okay in school. 10th grade basketball, he also had another concussion that set him back a little bit, some dizziness, some issues. So he had some PT for vestibular work, and his doctor recommended fish oil, which is wonderful, the omega-3s for brain health, and Tylenol. So he kept passing his test. He would go back, have some dizziness, and then get benched again. So eventually he recovered from that as much as he could. 11th grade, and that was when I met him. 2 big concussions playing football to the frontal, so he showed me those videos. And that was where he was still struggling with school performance, but his mom was mostly concerned about anger management and emotional regulation, because his coaches just really perceived him as being kind of a jerk, which his mom's like, he's not a jerk. We have a concussion, and again, you can't see a concussion, when you look at somebody. So she was really frustrated with how he was being addressed on the field. So again, these are his mom's goals for treatment, where it's anger management, memory management, and stress management. So where do we go with that? So literature review, it's really challenging in the manual therapy world to do research because, again, research in general, right? Like every person is an N of 1. And especially it's very hard to measure what we feel, and how to measure the changes that we make in tissue. And the latest research in manual therapy is, really what happens mechanistically. So as I did a literature review, there was one about manual therapy and concussion, and it was addressing headaches, dizziness, and neck pain, and which those were not of the symptoms that I needed to support. And it didn't talk about anything with regard to working with the cranium. It was mostly cervical, manual therapy, manipulations, thoracic manipulations. So another really good literature lit review discuss some of the mechanisms that they're exploring, like, well, when we do work with tissue and do manual therapy techniques, really what's happening on a cellular level, neurological level. So lots of things are happening. We're still trying to figure those out. But again, most of the techniques were mostly spinal manipulation, cervical, thoracic, and lumbar. I did come across a great case study from an occupational therapist who specialized in cranial sacral therapy. So some of her research that she pulled in started to talk about the anatomy with regard to lymphatic drainage of the brain, the cribriform plate, the dura, and cerebral spinal fluid flow. So that was exciting to start to see, here's impact and here's anatomy, what's happened to the anatomy when impacts come into the system. And then the last piece of research, it's from Artem Papatuin. He was the 2021 Nobel Prize winner, and he discovered the PZO1 and 2, which is a protein that converts mechanical stimuli into the signals that we interpret. So really that supports what the human hand can feel. And again, as we train our hands, and it takes years to develop the sensitivity and palpation, but we really can develop sensitivity in our hands, and I'll show you what we're able to feel. So manual therapy, again, most of it, we think about musculoskeletal, we think about pain. And then I'm going to talk mostly about visceral manipulation. So again, we're going in the container, so we're not just working with muscles or joints. We're starting to go a little bit deeper. Okay, what can we do to affect the dura? What can we do to affect ligamentous relationships with regard to organs? And again, we can't directly touch them, but like I said, with regard to sensitivity of our hands, that hand can very, very, very subtly intend to feel the layers throughout the body. And it's all about precision and feel. So the symptom survey form, so what am I going to measure? Because with every single person, I really want to know what changes am I going to make, what changes are they going to keep track of. The symptom survey form, Dr. Amen, Daniel Amen, he is big in the brain health region. And this is based off a survey that he created in his book, Making a Good Brain Great. My mentor for her, the concussion class that she teaches, adapted it for us. So as we all know, the brain is not black and white, but for the most part, here are some of the duties that the frontal lobe is responsible for, the temporal lobe, the cingulate gyrus. And what I did here is I underlined the ones that Jake was struggling with. So back to how's that frontal lobe doing for him? How's the cingulate gyrus, basal ganglia, limbic? So all of those are correlating to some of the symptoms, and it's an inventory. So he fills it out, and then I had his mom fill it out. So I compared his and hers, and then we're able to get some data. I hope someday we can explore this further and use this as a test on a regular basis, bringing some validity and reliability to it, but it's not there yet. But it gave me the data that I needed. So as you see, December 2024, those are his chief complaints, and that was how he scored on his symptom survey form. So that frontal is hot, that temporal is hot, right? Emotional control, emotional stability, cingulate gyrus, basal ganglia, cerebellum. So I think about, okay, where did he take most of his hits? That hit in 7th grade, he hit the back really, really hard. Those frontal hits in football, his junior year. So back to how did impact perhaps affect structure, perhaps affect the function of the brain. So again, I'm always looking for things to test. He didn't have visual trouble. He didn't complain of anything, but I just wanted to see what can I pre-test and post-test to see as I treat him, what changes did I make. So I looked at smooth pursuit, convergence, divergence, neural tension, just as there's tension in the neural system, the covering of brain and spinal cord blending into the nerve roots. His posture, he really hung out in a right side bend. So back to, okay, here's impact into the system, what's going on in a joint and or fascial roll into the cranium. And then also when I see posture-wise, when something is off, how well is the vascularity? How well is drainage in and out? How well is nerve conductivity? So thinking about posture, musculoskeletal, but also how does that affect some of these deeper anatomical structures that are important for the brain. Craniosacral rhythm, it's challenging to really, we're still working to define what that is, but very simply, we're looking at the flow of cerebrospinal fluid, and again, back to sensitivity of the hands. We're able to assess how well that flow is coming in, coming out. We're also able to assess how well is venous drainage coming out of the brain. And again, it's all based on what we feel with our hands. Hard to measure. So this is, how do I hit play there maybe? Oh, I'm sorry. Thank you. Okay. Awesome, thank you. Because, all right, here's my finger. Got it, perfect, there. Okay, I want you to follow it. It's very rudimentary how I test it and video it. So he struggles right about there. He struggles coming to midline. He just struggles. So also, so while he didn't complain of visual issues, I think about him in school and reading, how is there strain, whether mechanical, what can we do to improve that to just make decreased strain on his brain in everything he's doing? That's I'm not videoing it well. It's not going to work to video it up. That's okay. So intervention. So the cribriform plate, I'm going to be back and forth between a couple slides. It is just behind the frontonasal region, and it's an area of drainage of the fluids of the brain. And again, when we think about, right, we've got arterial blood coming in, we've got venous blood coming out, and the lymphatic system is that cleansing system of the brain, and all of those need to be functioning to make sure pressure is balanced and that the brain is able to cleanse itself from the metabolic waste that happen all the time. So there was lots of compression through that frontonasal joint, so we did some work to open that up. The posterior sinus is in the back. Here is, let me pop over to this one. So just in the front there we go. So this cribriform plate, so as we think about these impacts to the frontal, okay, how has that affected the structures, perhaps impeding some flow at cribriform plate. Back here is the posterior sinus, so this is where the venous blood is coming out. This is tentorium, part of the dura, and then we drain into the jugular veins there. So I worked posterior sinus, some OA decompression, cervical spine work. We got into the right eye, so I assessed the eye mechanically for tension, and then into the right supratrochlear nerve that we can access just right above that medial eyebrow. And it was really exciting. So this was just our first visit, and I'm always looking to collect data, so I took pictures before and after. So this is the same visit. There he was on the left, and then afterwards, as we just started to decompress, get a little pressure off, get drainage moving a little bit, just the openness and the ease, and his mom said, wow, I haven't seen that smile in a long time. So just a little bit of work to open things up, get a little tension off the brain, get the fluids moving a little better, just really took strain off his system. So I saw him for 10 sessions, an hour at a time, once a week, and those are some of the other structures that I worked on over time. So I retested smooth pursuit. It was much more smooth. Convergence, divergence improved. Neural tension improved. Rhythm improved. And there you can see, even just as we did the structural work, the differences in the posture left to right. And what was even more important for me is like, hey, I'm doing better in school. I'm getting A's when I was getting B's, low B's. And then I feel 92% better. So just encouraging to me that, hey, as we are addressing structure, function is starting to improve as well, and that's what's most important. So the symptom survey form, that's where he started in December. There he was in February, and 64% improvement, 65% improvement. So I was excited about the improvements, but we still weren't quite there yet. And one of the questions on the symptom survey form, the question is, do you have hopeless thoughts? And he marked that one pretty high still. So that was a big, big, big flag for me back to like, hey kiddo, how are you doing? How's your mental health? Where are you going? And what else do we need to do to support that? So, I let his mom know, hey, check in with your doctor. Just want to make sure we're good in that area. And then I also brought in a colleague who does neurofeedback, which neurofeedback is also supporting neuroplasticity with regard to the arousal states of the brain. So as we brought in neurofeedback, we retested again in August, and he was doing much better with regard to the symptom survey form.
So in conclusion, the direction and the specificity of the impacts directly affect the structure. And as these impacts, these forces come in and affect the structure, how does that possibly affect the function of those structure and therefore how that brain is operating? The trained hand can identify, assess, and improve the structure to improve some of that functioning with regard to fluid dynamics and tissue tension. And in my practice, I see a lot of patients with Alzheimer's, and a common factor in a lot of them are the old concussions. So how important it is for us to, as we start to see these patients with concussion, we start to learn how to use our hands, the anatomy, what can we do to optimize and restore some of those fluid dynamics, strains on the tissue, and how might that play a role in some of these later in life cognitive decline diseases that we see. And that is my research. And that is my clinic up in Cleveland. That is my QR code to my website. So if you have any questions, that's a great place for resources. And please reach out if you have any questions. Thank you. Questions?
Thank you very much for all of our presenters this evening. This will conclude the presentations. At this time, I would like to invite everyone to make their way to the back of the room. We'll have refreshments and the poster presentations for this evening. If you are a clinician, I would also invite you, a special announcement, at 7 o'clock, there is an Ohio Physical Therapy Association, a Northwest District event at Gillig Winery. Everybody else will have to wait till later. Okay, thank you very much.